So if any of you have a question, please feel free to raise your hand and we can take turns. Does anyone already have a question? If not, I have one. So clinical trials are essential for advancing treatment, yet many patients perceive them as a last resort. And Black patients remain underrepresented. So from your perspective, what can help patients, especially Black myeloma patients, feel more informed and reassured when thinking about clinical trial participation?
I want to give some thanks again for this small gathering, so it could be very informal, so please don't hesitate to ask me anything. I don't get offended, so you can ask me sensitive questions as well, so please feel free. So I want this to be more of a conversation than anything else. So if you have any question that you couldn't ask anywhere else, this is a free time. I promise I'll keep this confidential and nobody else would know that. So the reason of why this becomes so much of an importance, so for me, how I got involved with equity in cancer care is when I started as a practitioner, and I started here back in 2011. 2008 to 11, I was training. I was seeing most of the patients. When patients come to me, they couldn't ask me what they want. They couldn't ask me the right questions. I saw that for years and years, and I felt like there needed to be an advocate for my patients, and that's what led me into this patient advocacy. And I became a strong advocate for my patients who are minorities only because they couldn't ask the questions that they should be asking. So I didn't start with an agenda. This is what I have become, and I know most of you, or a few of you that have worked with me. And how it all evolved was in 2011 when I started, there were only 3 drugs. And over the next 14 years or 13 years, we saw 13 or 14 more drugs. And the numbers that are glaringly focusing at us are myeloma is predominantly seen in Black patients. If you look at the incidence in Black patients, Black males get highly affected. You take 100,000 patient population, 100,000 people, 16 per 100,000 is the incidence rate for a Black male. The same number for a white male is 7 to 8 per 100,000. The number for a Black female is 12 to 13 per 100,000. The same number for a white female is anywhere between 3 to 4 per 100,000. So if I were to make it simply, if you're not a numbers person, a Black male has a 4 times higher risk of having myeloma than a white female. So this is a staggering number. You don't see this in any other cancers. So when you look at the bigger picture, in the US, we have 12% African American patient population. If you look just at myeloma, the 20% population is Black. So what should our numbers be when we look at these clinical trials that I was talking about all along from 2011 to now, when we saw all these improvements, all these clinical trials, patients were getting access to these new drugs, and all the 20% population should be getting the same access, right? I want somebody to make a guess. What is the clinical trial participation of African Americans in the clinical trials? Miss, you're right. You're right. It's in the range of around 4%. So lots of factors that come into play. Number one, you got to be able to ask. You got to be able to, what is the trial that would work? A trial is not somebody experimenting on you. A trial is something that people have biases when they come in. Anyways, they won't participate. I won't be present in this trial. I'm very big on that. I do not want any of my colleagues to do that. My colleagues do a great job. But people shouldn't go into a room with a bias that even if I present the trial, the patient would not be participating in the trial. So when we go back to Grady, there is an ethicist that we work with, and we did a simple trial. In 200 patients, everybody was asked about a trial and a donation of a sample, or would you be willing to participate in a trial? There were no differences between Black patients and white patients. There was no difference. Everybody wanted to participate if they're offered. So I have offered clinical trials to a lot of you participate in the clinical trials. And what I see is the benefit from these clinical trials. We talked about 4%, right? I'll go back to asking Ms. McRae, what do you think is the number at Emory when we have these 100 patients?
So Emory's done very well with its recruitment of Black patients, and so I'd say of 100, maybe 18.
We are at 35%. Yep. So it's something that talks about our patient population, number one, and the trust that you put in us. And there you go. Like everybody that I see here has participated in some trial or the other. So I'm glad that people are utilizing it. By the way, Ms. McRae, I have to tell that story. Can I? So when I was new faculty in 2011, the day that I started, I gave a similar lecture. And Ms. McRae was there. And she walked to me afterwards. You were too complicated. You cannot show me all those graphs and not explain. You need to tone down. And that's a lesson. She is a teacher for me, right? Thank you. And I tell this story. So I learn every single time. No, I gave a disclaimer. I won't get offended with anything. You can tell anything to me. Good. And the same thing with Miss Daniels. I have known her for 7 years. I still remember the first day when I saw her. She had COVID on the first day. Participated in the trial. Now guess what? She's off treatment. Great. Thank you for your trust in the system, and thank you for participating. I'm open for any specific questions that you have.
I have a question. Can you participate in more than one trial at a time?
This is a great question. The trials usually don't allow. So there are some ways. It all depends on the specific trial that one is enrolling on. So, for example, if somebody enrolls on a CAR-T trial, so the examples are CAR-T was a very unique treatment, right? So people didn't have access to these treatments before. And when we had this access to treatments, these are good. We know that these are so good. We want to offer these to the treatments. And 50% of our patients are Black patients. Nowhere ever in the country that you had seen that kind of a number of patients that we had. So far, we offered 250 patients, commercial CAR-Ts and research CAR-Ts. When we look at these, 130 are Black patients. So we also have to look at where exactly, are there any differences? Are there any differences in the CRS rate so that we could learn more and be more vigilant? When we look at those, so there are visible differences that one can see, but the good thing is the safety, the benefit that one can get is almost similar. So there are no downsides. We're allowing it allows us to go back deep into looking at the adverse events, the benefits, and suggesting, yes, this is a treatment that one should go with. Yeah. So to answer your question, those CAR-T treatments, they have follow-up. So even the CAR-T is done, they have follow-up for 15 years. So one can enroll in a trial like that, in a separate trial, even though you're in a follow-up. So that's an example. But most trials, 2 interventional treatment trials, you cannot enroll at one time. Ms. McRae.
So Dr. Nooka, you talked about trust, and I would love for Emory and the Emory family not to lose the trust of patients. There's a history of clinical trials, and we know the benefit. I mean, we've seen the benefit in myeloma, in the myeloma space, for all patients, including Black patients. So we want to increase the number of patients on clinical trials. You've done an incredible job of education about clinical trials. I don't want for people to question whether they are being offered, for Blacks specifically, to question whether they're being offered a clinical trial because one wants to increase the number of Black patients on that trial versus whether it's the best treatment for them at that time. I got that, in my treatment history. And so I just have a nervousness about that. The second thing is I wish there were a checkoff list for patients. So they could, because clinical trials are so complicated, because they do have, these 20 pages of medicalese and, things like that, and we don't know what questions, we don't know enough to ask all the right questions. If there were a checkoff list that would help us to figure out whether that clinical trial is a good fit for us individually. So, I mean, that's sort of an ask for the future or something, but that first is a real concern for me.
Great. I think this is a great question to have this conversation. So to bring everybody up to speed of what exactly Ms. McRae was bringing up to is because there is a lower number of clinical trial enrollments. So there's an act that was from the FDA. It's a Consolidation Appropriations Act, basically saying that every clinical trial should enroll an X number of minority patients. So that number for myeloma is 15%, is where the number came up with. If the clinical trial is not accruing 15%, there is a, I would not say it's a mandate. This all took the backseat during the time of COVID, but it is a moral responsibility for every sponsor to fill that 15%. What if it's a bad trial? What if it's a trial that is not helpful for the patients? In order to meet that numbers, to require that numbers to be filled in, are you offering me that trial? Is what the question was. So this again goes back to asking one simple question to your provider: tell me, how is this trial helpful for me? And my patients really openly ask me, and if I can't answer that, if I get offended, that I should not be a physician. So you have to ask that, what is it in it for me? And there may be an answer, like, you could have other options. What are my standard of care options? Are they as good as this one, as the clinical trial? There are always the discussion that needs to continue. If I take offense to any of those questions, then I should not be a doctor. Okay. Mr. Vicker.
My question was just regarding the clinical trials. I know that I'm an advocate of clinical trials, and there were a few clinical trials that were put in front of me. I just wanted to know now, with the new administration, and I know I have friends at the NIH that are saying a lot of clinical trials are being targeted with funding reduction or just wiping it out, and DEI also plays a part. Myeloma, obviously is heavily minority. Are you finding problems with clinical trials being halted due to funding?
This is a great question, Mr. Vicker. So I think going back to the trials that we presented to you, the way what works, the standard of care regimen works much better for you in that space, and that's exactly what was offered to you. So coming back to the clinical trials, how much are we affected with the current changes in the administration, the government? There is think about it as two buckets. One bucket is clinical trials that have sponsors. So an industry sponsor like Pfizer, like Janssen, they're sponsoring clinical trials, and they're the funders. Number two, I have basic scientists that work with me. So those basic scientists are the ones that get the funds from the government, where they would say, you get an X million of grant, and in year one, you need to show me that outside the human body, these samples are working this way. And in the year 3, these animal models are working, so at the end of the day, we have a product that is ready for human development. So that part is all never sponsored by a sponsor. So it is not coming from Janssen, or it's not coming from Pfizer. It is the government that has to sponsor for this drug development to happen, so that we have all the basic technology that is available. They have their own individual institutions where they do all the R&D with their products. But in terms of discovery, we have the basic scientists that are heavily invested in, that we work with them on a regular basis. And those are the ones that are affected more than us. So we have the private sponsors, so we have not lost. So again, all the sponsors are interested in the same drug development, and we provide them, and we have the access. So that part is not affected as much. But if you look as a whole, we are measured as an institution. So all of what falls into as an institution. So if all the research funding is X, we drop down by 20% in terms of the research funding to do what we have to do. So I didn't know if I answered your question, but a part of us, yes, absolutely, were affected. Yes, sir.
So my wife is recently diagnosed with ML, and I've got plenty of questions, but I'll try to limit it. First question is, thank you. The first question is, and I know this is very sensitive for a lot of folks who have gone 2 different routes, but do you have a general recommendation as to, does the data support that stem cell transplant has more success associated with it than non-stem cell transplant? Because we're coming up on that in about January of this year. And then the other question is, any comments on whether or not a 3 or 4-prong regimen, one or the other is better during the treatment leading up to the chemoblast?
Yeah.
Thank you.
I'll answer your second question first, because that's easy. 4 drug regimens are better than 3 drug regimens. So we have shown it consistently. All the trials have shown exactly that. There is not even a single study that showed the opposite. So that's an easy answer. There's a small portion to that as well, because when we looked at the 3 drug regimens, we used it all the way until 2018 or 2019. So when we started to look at the 4 drug regimens in a small clinical trial that was before any of the current trials were available, most of the patients, we enrolled close to 20 patients on that 4 drugs because we believed those 4 drugs would work. And every patient that we put on the trial is getting a CR, getting a complete remission. And that's what led us to say, we don't need any data. We're seeing it right in front of our eyes. And we changed to 4 drug regimens even before any of the regimens existed. So that has helped us to get patients into deeper remissions. And because most of our patients, when we put them on the trial, they were all African American. So we asked the specific question, are African Americans getting similar benefit or better benefit of the 4th drug? And the daratumumab was highly, highly beneficial in the African Americans than even we published this, than even in the Caucasian patient population. I can't tell you the biological reasons of why, but these antibodies, the immunotherapies, were heavily helping. So I hope that answers the 4 drug questions. The transplant question is the one that can get a little tricky. So years ago, when we didn't have good drugs that are giving a good response, transplant is making up for that loss of that benefit. Now, with such new drugs, getting to an MRD negativity, what's the need for a transplant? But it's a short-term endpoint. We don't know the answer. None of these trials have looked at 10 years from here and say, hey, one is better than the other. So far, all the trials that had shown this benefit of patients living beyond the 15-year mark or so are all transplant studies. The non-transplant studies are the ones where they had shown benefit almost 5 years lesser or so. In a younger patient, if they got a really good response, I would not show with the transplant, but I would at least collect the stem cells and basically question, what is the need for me to go for a transplant now? So younger patient, great response, and having no high-risk markers. So there is an opportunity for us to have the discussion rather than jumping directly into the transplant. So that's why I was saying it's not an easy question. It's a complex question. If you asked me even a couple of years ago, I would say definitely yes for a transplant. Yes, sir.
Thanks. Sean Reynolds. I'm a patient of Dr. Loniel's. I'm active actively engaged in one of the studies, and I just really wanted to share my experience, and I can see it being a barrier for why we don't have many in our community wanting to actively get engaged. Not so much, this could be for you and for industry. My issue was the financial component of it, tracking that. For those who aren't in a study, you still need to use your insurance. But if you're in a study, the financial component of what that study is requiring, additional tests, drugs, the sponsoring company is supposed to take care of that. The tracking mechanisms need to be improved, because I had to chase down for 6 months. No, these charges are for the study. These charges should not be going to my insurance company. Then I have to contact the insurance company, explain to them, well, Emory needs to send it back to us correctly. And when you're going through the stress of this disease, coupled with life stressors, working and things, it's overbearing. And I did not want to put that on my wife, because as a caregiver, it's stressful enough dealing with me. Now, this financial component, I felt I needed to follow that through. There's no excuse with databases and computer systems, AI, to not be able to separate these charges and reduce that financial stressor. So I guess my contribution here is more of a comment and an opportunity to improve the process, so that others who may not be as financially well off aren't scared away from participating in a study.
Great comment, and this is really wonderful comment. I'll give you some background of how this all happens, and I'll take some feedback as well. So the question that is looming in everyone's head probably is, how does it go? Which lab test goes to the insurance, which lab test goes to the study? It is all based on, so as Sean pointed out, if you're on a maintenance study, I'll give you an example. You're on a maintenance study and you're taking Revlimid once a month. So what is standard of care is, your Revlimid is standard of care, coming here once a month is standard of care, and doing the myeloma labs is standard of care. So if you participate in a study, the study says, like, I want an extra set of magnesium, extra labs of magnesium to be done. And the first 3 months, I want the patient to come 2 times rather than one time. So anything required as a part of the study, it goes to the sponsor, it's billed to the sponsor. So the extra magnesium tests that we're ordering, the extra visits that you're coming, all of them are bound to the sponsor. So before even the study opens, all this is put in a tabular form, what goes to the study, what goes to the sponsor. And every single time a bone marrow is done or a test is done, so the study coordinator basically looks at it and says, goes through what was written there and says, this is where it belongs, this is where it belongs. There's a human component there. That is the biggest problem. If the middleman is who has to review and puts one way or the other, it changes the entire equation. And we try to take those people to train and train and train. They do a wonderful job, but unfortunately, there's always somebody that doesn't do it, and it brings us back to a problem that we shouldn't have. I'm sorry for what you went through, but this is a real problem. I cannot agree more. And we have been, I can say, we're way better than where we were last year. That's not an excuse, but this is an ongoing process that we're continuing to improve. But thank you for bringing that point.
I think we have time for 1, maybe 2 questions, and then the ones that we don't get to answer, you can write them down and we'll have a Q&A later.
My name is Flora, and I'm Dr. Nooka's patient. Since I started treatment, one of the problems that I've noticed is dental issues. I just want to know if multiple myeloma is responsible for problems with dental issues. And if it is, what can we do?
So myeloma by itself doesn't cause dental issues, but the steroids that we use have an impact on the dental issues. The Zometa that people get have an impact on the dental issue. Those are the two big things. So in the past, we used to give the Zometa or the bisphosphonates almost for 5 years, 10 years. We started to see the benefit is not there anymore. The bones become ossified, the bones become brittle. So, and they have a higher chance of breaking when people are on these long-term bisphosphonates. Right now, what we do is for the first year, we give it every month, and then every 3 months for the second year, and stop it. So that has reduced our dental issues drastically. Same goes with the steroids. So in the past, we used to use a lot of steroids. Now, our goal is within the first year or two, most people should be coming off steroids. So that has resulted in a reduction in most of these issues, but unfortunately, the amount of steroids that we use in myeloma is higher than any other blood cancer.